In this video, we'll be talking about the abdominal aorta, its anatomy, branches, and clinical relevance. As the continuation of the thoracic aorta, it plays a key role in supplying blood to the abdominal organs, the pelvis, and the lower limbs. To do so, we will start by a brief introduction, followed by detailing the descriptive anatomy of the abdominal aorta, its collateral and terminal branches. We will explore some clinical applications and the approach routes to this great vessel. And finally, a conclusion to summarize all the key points. The abdominal aorta is the terminal portion of the descending aorta located within the abdominal cavity. It serves both as a conduit artery for the lower limb and as a nutritive artery supplying most of the abdominal and pelvic organs. Let's start with the descriptive anatomy of the abdominal aorta. The abdominal aorta originates at the level of the aortic hiatus, opposite the inferior border of the T12 vertebra. It is located in the midline retroperitoneal space and descends vertically, slightly to the left of the midline. It terminates by dividing into three branches: the right and left common iliac arteries, and a small branch called the median sacral artery. The aortic bifurcation is located in front of the L4 vertebra or at the L4-L5 intervertebral disc. The anatomical relations of the abdominal aorta, at the aortic hiatus, are posteriorly, the thoracic duct, and the medial root of the hemiazygous vein. Along its course in the abdomen, the abdominal aorta is accompanied by lumbar lymph nodes, classified as preaortic lymph nodes, lateroaortic lymph nodes, and postaortic lymph nodes. Anteriorly, from top to bottom, the body of the pancreas, the horizontal portion of the duodenum, and the small intestinal loops. And posteriorly, it lies against the lumbar vertebrae from L1 to L4, over which the lumbar veins run. On the right side, it is related to the cisterna chyli and the thoracic duct, the right celiac ganglion, the azygous vein, and the inferior vena cava. On the left side, it is related to the duodenojejunal flexure and the sympathetic trunk. Let's detail now the collateral branches of the abdominal aorta. They are divided into three paired and symmetrical groups: parietal branches, urogenital branches, and visceral branches that are unpaired. The parietal branches are first, the inferior phrenic arteries. These arise just below the aortic hiatus and ascend in front of the diaphragmatic crura and branch out beneath the diaphragm. The lumbar arteries come in four pairs. They originate from the posterior surface of the aorta, at the mid-level of the corresponding vertebral bodies. The right lumbar arteries pass behind the inferior vena cava, and also posterior to the quadratus lumborum muscle. Now the urogenital arteries, composed of the renal arteries. The left and right renal arteries are the largest of the collateral branches. They arise from the lateral aspects of the aorta at the level of L1. They run obliquely downward and laterally toward the corresponding kidney. The right renal artery is longer than the left and passes behind the inferior vena cava. Before reaching the renal hilum, each renal artery divides into two branches: an anterior prepelvic branch and a posterior retropelvic branch. The gonadal arteries, testicular or ovarian, originate from the anterolateral surfaces of the aorta, at the level of L2 or the L2-L3 disc. The testicular artery descends through the lumbo-abdominal and pelvic regions. It traverses the inguinal canal and follows the spermatic cord, and ends at the upper pole of the testis, where it ends in two branches: a lateral branch and a medial branch. Now onto the visceral arteries. The celiac trunk arises from the anterior surface of the aorta, at the level of the T12-L1 intervertebral disc. about 1 centimeter below the aortic hiatus. It descends obliquely downward and forward, reaching the upper border of the pancreas, where it divides into 3 terminal branches: the common hepatic artery, the left gastric artery, and the splenic artery. The superior mesenteric arteries arises from the anterior surface of the aorta at the level of L1, just below the renal arteries. It descends vertically behind the pancreas and terminates near the jejunum. It is related, posteriorly, to the left renal vein, anteriorly, the body of the pancreas, and to the right, the inferior vena cava and the superior mesenteric vein. Collateral branches include the inferior pancreatico-duodenal artery, the jejunal arteries, the right colic artery, and the middle colic artery. The superior mesenteric artery supplies blood to the entire small intestine and the right colon. The inferior mesenteric artery arises from the anterior surface of the aorta, at the level of the L3-L4 disc. It runs obliquely downward to the left toward the left common iliac vein, then turns vertically downward. It ends as the superior rectal artery. At its origin, it is covered anteriorly by the horizontal part of the duodenum, crosses over the aorta and the sympathetic trunk. As it continues in the pelvis, it is related to the psoas muscle, the ureter, and the gonadal vessels. It supplies the left colon and the pelvic rectum. Let's tackle now the terminal branches of the abdominal aorta. The abdominal aorta bifurcates into 3 branches at the level of L4. 2 lateral branches, the left and right common iliac arteries. 1 medial branch, the median sacral artery. The median sacral artery arises from the posterior surface of the abdominal aorta, and it descends along the anterior surface of L5 and the sacrum. The common iliac arteries are primarily conduit arteries. They arise from the aortic bifurcation and are short and voluminous. They terminate by bifurcating into the internal and external iliac arteries, near the sacroiliac joint. One of the most frequent pathologies of the abdominal aorta is the abdominal aortic aneurysm. An abdominal aortic aneurysm, AAA, is a localized dilation of the abdominal aorta, usually occurring below the renal arteries. It is often asymptomatic until it reaches a significant size. Risk factors include age, hypertension, smoking, and a family history of aneurysms. If left untreated, an AAA can rupture, leading to life-threatening internal bleeding. Surgical intervention, either through open repair or endovascular aneurysm repair, EVAR, is typically recommended when the aneurysm exceeds 5 cm in diameter, or if there is rapid enlargement or symptoms. The approach routes to the abdominal aorta are 2. Median xiphopubic laparotomy, this is performed from the xiphoid process to the subumbilical region. And bilateral subcostal laparotomy, the incision is made 2 finger widths below the costal margin. To conclude, the abdominal aorta is a vital artery that supplies blood to the abdominal organs, pelvis, and lower limbs. It is crucial for the distribution of oxygenated blood to these regions and is susceptible to various conditions such as aneurysms and occlusions. Early detection and surgical intervention are essential for preventing complications, especially in cases of aneurysms. Understanding the anatomy and function of the abdominal aorta is critical for both diagnostic and therapeutic purposes in clinical practice.